Everybody. Marianne Howie, I want to welcome you all to Cord Connects, and thank you for joining us. As I'm assuming you all know, this is a recorded session that will later be available on the Cord website. I want to express a special thanks for Dr. Steve McGuire, who has essentially pulled this talk together in record time. He is an attending physician in the Department of Emergency Medicine at Boston Medical Center, and holds the position of assistant professor at the Boston University School of Medicine. He is passionate about the intersection of education and technology. I had the pleasure of seeing part of this talk already that he did at MEMC in talking about the bias that can be introduced into AI. But what we will be talking about today is a more comprehensive talk that will provide an overview of artificial intelligence in emergency medicine education and training, with objectives including the overview of current and potential benefits of AI in the student resident education, overview of current and potential concerns of AI, and more focused concerns specifically on current and potential impacts of bias within the use of AI. Dr. McGuire, thank you so much for joining us. And thank you really for coming to the fore to be willing to do this talk so quickly.
No problem. Thanks for having me. I appreciate it. Thanks for those of you who have joined. I appreciate it. Let's see. I am not a pro at this, so bear with me while I try to share my screen. And welcome to Boston. And I hope you're not allergic to cats in my house here. So let's see, share here.
I will add just one more thing, Steve, which is if as we go along, if people want to throw questions into the chat, and that way we can address them as we go along. At the end, and that way they don't get forgotten.
I actually have included, as this slide might suggest, some time for interactions along the way. I will beg those of you who are with us live today to interrupt. All of my talks are meant to be given in IRL, as they say, and so I would appreciate it. In fact, I'm counting on it. If you have questions, feel free to just interrupt me. I'll try to build in some time to to break for questions during the talk, but you can also feel free to put it in the chat, and maybe Marianne, you'll be able to break in if people do not feel as comfortable as I know you will to interrupt me. So this is just that reference to let you know that I tend towards the Socratic. Let's see if I can make the slides advance. Great. I always put my thank you slide at the beginning as well, because I think it's the most important part. I appreciate the opportunity, Dr. Howie and Cord Connects, for inviting me, and for those of you who found the time to join us live, and for those of you who are watching me recording, I'm sure I aged well. The first slide here also gives me an opportunity to say thank you to you all for bearing with me as I present a video from one of the classic, future of emergency medicine series that is Star Trek Voyager. And as I hit play, just maybe keep an ear out for some of the topics that we might be talking about in the next 20 or 30 minutes, and maybe reflect on them as we do. Let's see how this goes.
Steve, there's no volume on this side.
No volume on that side. Okay, well, that's perfect then. So this is just a video whereby the emergency medical hologram is asking, what he might do if he had the ability to program himself, and it would have been great, I'm sure. We'll move on. The topic is basics and bias of AI in emergency medicine education and training, as Dr. Howie pointed out. And the sort of colloquial title is going to be "Please state the nature of the medical emergency." And for those of you Trekkies out there, you'll know from whence that comes. My information is there. I'm Steve McGuire. I work, as Marianne said, at Boston Medical Center as an attending physician in the emergency department, and as faculty at Boston University. Contact by social media is there, including both Twitter/X and and alternative means, including my email. Feel free to send me an email at any point. I have no conflicts to disclose. Dr. Howie sort of went over the goals here. This is just a rehash of that. We're going to talk about the current and future, or current and potential benefits, I should say, of AI in emergency medicine education and training. We'll talk about the current and potential future concerns for the same. And again, we'll take what was the talk that we had in Greece and spend a little bit of time focusing on bias and potential bias as it relates to the implementation of AI in our sphere. There's already a chat. Let's see if somebody said something nice. Oh, okay, I can't hear the dialogue. Okay, great. The starting off point here is that we should all sort of agree that it is likely, if not inevitable, that we will be dealing with AI, artificial intelligence, in our future, perhaps not so distant future lives. And we'll first talk about the potential benefits. And we'll focus on individualized education first, trying to sort of keep an eye on how this might influence our medical student trainees, sub-Is and MS3s in particular. We'll talk about access to evidence-based medicine in the AI era, help from AI in differential diagnosis production, access to knowledge via AI, use of AI to help with OSCEs in test prep, and even in just helping us write, for instance, research, proposals, etc. Let's see. One of the very easy to understand sort of ways to access AI today is in the rapid production and accession of evidence-based medicine. You could, for instance, use it in much the way we would use the internet yesterday. That is, you could Google, what is the summary of the SALT-ED trial? You could certainly imagine, I could imagine myself asking a learner, what is the importance of, the SALT-ED trial on our choice of intravenous fluids? And that learner might be expected to sort of come back and summarize it the next day. Well, it might not take that long. If you type this phrase into one of the AIs, Google Bard or ChatGPT, etc., you will get in 4 or 5 seconds a pretty good summary of the SALT-ED trial. This is an example of that. Describes the sort of overall characteristics of the trial, who was involved, some basics on the results, and an interpretation and conclusion. And it's pretty good. It's short and sweet, but certainly gets the point across with the final sort of trial conclusion that we should be considering balanced crystalloids instead of saline in our non-critically ill patients who get IV fluids in the ER. So not bad. You could even, as we should be doing, try to encourage our learners to think critically about that evidence. And, maybe they came back with that summary and you said, okay, well, what are the criticisms, provide a critique of that trial. What's good and bad about it? And, you turn around and put that right back into your ChatGPT prompt. It could give you something like this. Again, very appropriate, sort of straightforward. It points out the, generalizability problems, et cetera, all very reasonable. And again, as far as I could tell, true. We're not going to talk a lot about the potential for hallucinations and misinformation or sort of bad information, hallucinations that we can talk about, but this is pretty good. So beyond just using it like we might use Google or another search engine today, what else can you do? You can use it to help practice the generation of a differential diagnosis. Again, focusing here on the education part, maybe the level of an MS3 or an MS4. There are tools out there to help. The sort of straightforward ones that most people are familiar with are the ChatGPTs, the Bard, the Bings, and other large language model AIs that are out there. But there are also some more specialized AIs GLASS and TALI are two that we'll talk about briefly today, that are more specific to the healthcare professional in training or otherwise. For instance, GLASS is an AI that seems to be sort of focusing their efforts on the healthcare, on the physician or other medical provider, to help them generate differential diagnoses, and in fact also action plans based on those differential diagnoses. And you might enter into the GLASS AI a prompt like this. A patient experienced sudden cardiac arrest after presenting with acute chest pain postpartum 3 weeks. That's not a lot of information, but it will do for this AI. And with that small piece of information, it'll generate a differential diagnosis. And GLASS AI example here shows the sort of summary of the case. Although there's very minimal information, it does a pretty reasonable job of generating a differential diagnosis, including its best guess of peripartum cardiomyopathy, alternative diagnoses, including acute MI and PE, which I think would be what we would expect from a learner. And you could even broaden it with an alternative diagnosis and things that might lead you towards that testing to do, etc., including things like amniotic fluid emboli, postpartum thyroiditis, SCAD, arteries, dissections of the various important arteries of the body. And so that's a little different than just using Google. It's obviously more geared towards the healthcare provider, and could be useful in the training of our emergency medicine sub-Is and even interns. TALI is another device geared towards the healthcare provider. It's another AI. This is in the form of an app that I think is meant to sort of overlay your EMR. TALI is able to record conversations. Obviously, you would bring this into the examination room, and it would record your interaction. This is a very brief transcription of an interaction that I had with TALI, where I played both the physician and the patient, and you can sort of see how it goes. It's asking about a shortness of breath and, running through a very brief history of it, ending in the sort of tendency towards asthma as the diagnosis. This is just a transcription. The transcription is automatically converted into a SOAP format by the TALI AI. So you can see that it's taken our interaction and placed all of the subjective information into the S part of a SOAP note. We didn't, in my fake interaction, talk about like physical exam findings, but you could imagine if I had said that, oh, I hear wheezing, but your oxygen saturation is 98%, that those would be placed into the objective part of the note. It's even formulated an assessment, and in more complicated situations would give you alternative assessment possibilities and a plan of action to sort of go on that. So this is a very good starting off point for like a sub-I or an MS3 to sort of help be the beginning point of a conversation about how you might attack a patient interaction, a particular case, as it were. All right, I'm going to just take a quick pause here and see if there's any questions before I go on to the next stop. Anybody have any questions for me, please? All right. I'm going to awkwardly pause and allow anybody to think about it. All right, great. So moving on, more educational content from our AI overlords. There is already a commercial commercial app called Oscar from our colleagues down under. Oscar is an AI dedicated to the provision of OSCE cases, so that you can practice the history taking and plan making for various sort of free situations. And you can see some examples that are there. And obviously, you can buy more cases so that you can practice your history taking and plan making at the expense of the Oscar folks. An example of that would be this brief interaction, again, sticking with the shortness of breath modality. It did not take long for Oscar to tell me that I was not very good at taking the history. After 2 or 3 questions, I asked the Oscar patient a compound question about fevers or chills. And the AI said that that was probably not the best way to take a history because it might confuse the patient, and gave me some suggestions on how I might better take a history in the future. Moving on from the OSCE situation, which, like I say, I think can easily imagine being useful for students at home, and obviously can be used in the educational setting. You can also imagine already the ability to create tests pretty easily. You can punch in a series of parameters and topics, and various of the GPT type AIs will create a test with multiple choice questions, including right answers, foils that seem reasonable, explanations of those answers, and even links to educational content to support and or remediate the understanding of that topic. There is also, as you might imagine, commercial endeavors to do the same. Atris.ai is another application that you can pay a reasonable fee, I'm sure, to help as a pre-medical or medical student, to help you gear up for your studies and make the most of the opportunities you have to further your career. I will say that in my sort of interrogation of this system, it wasn't particularly helpful to me, but it does have access to quiz generation, resources on tools that will help you understand concepts. I think its big goal is to have a community of learners. So there's a chat box that includes the AI and presumably learners from all over the world that you can ask questions of, and the AI will help facilitate and provide answers where your colleagues might not be able to. Okay, so that is sort of the majority of what we wanted to talk about as far as the individualized education that could be provided from AIs or facilitated by AIs. You could, as we said, imagine a situation where you could ask the AI to maybe write an introduction to help you get through that first stumbling block of writing a research proposal or a summary of some topic that you're trying to present for conference, etc. We won't talk too much about that, but there are certainly examples in the media of how things that like that have been done, including in the voice of a British physician of the 1900s. You can make the AIs do pretty much anything you want. We're going to move on to personalized training, a lot of which overlaps with the education. Pardon me.
Steve?
Yeah.
Can I ask, as probably the resident boomer in the room, where is it getting its information from? Is this essentially it's scanning the internet and it is generating information from sources like a Google search would? But
yes, the answer is yes. The large language models that you're most familiar with, ChatGPT, the Bing AI, Google Bard, are basically trained on the entirety of the internet. So I think the data that I've heard is 175 billion, I think. Yeah, 175 billion, pieces of information out there in the world, all of which are of various levels of quality. And so based on that model based on that data set involved in training the model, the evidence itself or the information itself that it brings is subject to that same concerns about equality. And there's a term which sort of I alluded to earlier, where I talked about hallucinations, where there is another term that refers to infodemics, which is basically the either accidental or not accidental impartation of false information. So you can sort of think of it as the fake news of AI. So I didn't talk about it there, but if you ask that the AI that I was asking about the SALT ED trial to give you the citations for that trial, it will provide a set of citations which look very good, including DOIs and articles, but they're false. They're just made up because the language model doesn't always know what is an actual piece of information. Or my interpretation is that the language model doesn't know what is fact and what is language. And so it will create language. That's one of their skills, is creating human sounding natural language. based on its experience of 175 billion pieces of human language. But a citation is not language. And so the machine gets it wrong quite often for citations. So if you ask for the citations for a lot of things on these common AIs, it will give you a citation that looks natural. New England Journal of Medicine, 2022, pages such and such to such and such, DOI number. But if you actually go and look that DOI number up, it will not be the article that cited. That article may not exist. And you could even ask the AI, hey, it looks like you made a mistake on this piece of citation. Is that true? And the AI will acknowledge, oh yeah, that's not true. I apologize. I made that up. But it's a very common thing. And if you don't know when to ask, is that true or not? Or if you don't know how to follow up to make sure that the evidence that ChatGPT has given you is factual versus creative, then you're going to be in between a rock and a hard place. Does that make sense?
So
I was muted. Thank you. Yes, it does. Thanks so much.
Okay.
So
any
Steve,
other questions?
This is Pam. Can you hear me?
I do, Pam.
My mind is blowing a bit right now because what you're saying is it's searching the internet for evidence and creating something that's a summary that's coherent and generally true, but the citations that it's giving are made up.
Correct.
Right. So, okay. Just wanted to emphasize that because that's like really scary.
It is very scary. And so that's the problem with these kind of things right now. That if you just trust blindly, just like if you Googled, is it okay to use normal saline instead of lactated ringers, you would be able to find citations in the world that say one thing or the other, and not knowing the value of those is, like it has been for all of time, a problem. And so you have to be able to teach the critical thinking that goes along with it. And one presumes that these large language models will get better about these things, and that there will be some entrepreneurial spirit who is able to monetize this in a way that creates a more accurate AI that'll allow us to bypass those things. Other questions?
Does it learn from its mistakes? For example, if you point out that the reference was wrong, does it learn that, like, oh, that was wrong, this is where that data comes from, and won't make that mistake again, or it's not that smart?
I will say yes and no. There have been times where if you pester it enough, in my experience, you can finally get it to say, oh yeah, no, I also made that up. Oh yeah, I also made that up. The actual journal is this, but it will also just continue to make things up. And it's kind of like I was in junior high school. It will say it with great authority or air of authority and confidence, but have no idea what it's talking about. Other questions? Thank you for those questions. I count on them because otherwise it's going to be a very short talk. Not that that's bad either. This out of the way. So moving on to the trainees, sort of like I say, this is a lot of crossover, but we're going to focus a little bit more on how it might be done for the residents, and in particular, keeping in mind as the resident directors that you are, how it might be used in that sort of use case. We talked about GLASS and Tally. You can sort of see that those could be used, especially in the early years of training, to practice, remediate some of our learners. But we also want to focus on some other things. There exists already in some of our other specialties, folks who have taken in the academic setting and put the training for our residents into an AI type modality. In particular, a lot of the image-based specialties, radiology, dermatology, pathology, even things like retinopathy, where a lot of diagnosis is based solely on image, which you can imagine is quite an easy task for AIs to do, because it's basically pattern recognition, and so AIs are quite good at that. In those cases, like radiology, there are people who've taken that ability to use image pattern recognition and combine the AI skill at that with the training of residents to do the same pattern recognition. There's one academic institution who has a large neuroradiology teaching file of 1,000 or so images meant to represent the breadth of both the common cases as well as the important rare cases that they expect all of their trainees to be familiar with. And what they've done is created a system using an AI to track the assessment of residents in terms of which diagnoses and image modalities they've seen in clinic, in practice, while they're at the hospital. And when appropriate, provide them with either repetitions or insert cases that they have not seen but need to see into their training. So that, if they haven't seen a particular case of, I don't know, a cerebellar stroke, because they just haven't been unlucky enough to do that, then the AI will recognize that it hasn't been done as it keeps track of the diagnoses that they're making in the clinic, and then prompt them to study some of the 8 or 10 cases of that diagnosis, or maybe that imaging modality that the AI has determined that they need, in order for them to sort of be adequate in what the radiologists think is important pieces of information. That is pretty straightforward and makes sense. And it should be pretty easy for those of us involved in education to, I don't want to talk about that yet, going back. Should be pretty easy for those involved in education to translate to the emergency medicine sphere. If not, MRIs of the brain that we're expecting our PGY 1 and 2s to sort of know, certainly do expect them to be able to look at a case file of EKGs or a chest x-rays, maybe other important images. And also, we could do the same, imagine easily the same for critical procedures that we expect our trainees to sort of understand and be exposed to. Not everybody's going to be able to do 10 thoracotomies in their 3 or 4 years of training, but we expect people to know how to do them. Same thing with, canthotomies or other sort of rare but important skills that we expect people to do. And for those that don't get enough in the emergency department, we can supplement that with AI prompted sessions to the sim center, or maybe AI prompted OSCEs where they learn the same thing self-directed at home or elsewhere. Speaking of AIs that we can be using in the emergency department pretty quickly that are sort of pattern recognition, emergency department reading of EKGs is perhaps one of the most fraught sort of areas of our liability. And those of you know Steve Smith and his colleagues, Pendle Myers, have collaborated with some folks in Europe to create an AI whose job it is to read EKGs, and they've not yet released it in the States, but do have a working model of this in Europe that is, what do you call it? Authorized to be a medical device in Europe to read EKGs, and it has demonstrated pretty astounding sensitivity and specificity, and in particular in sort of the Steve Smith OMI paradigm of reading ECGs. You can sign up for this as a sort of, not beta tester, but a pre-release person here in the States. I suspect that in the next 12 months or so, there'll be a FDA approved Queen of Hearts app to help us all read EKGs for OMI in the near future. This is what I was talking about before, the idea that a lot of these things could be translated to the emergency department training sort of paradigm, procedures, critical diagnoses, etc. Also, I think sort of the low-hanging fruit here for a lot of AI in education and training is the idea that you can ask the AIs to create cases, a sort of infinite number of cases, similar themes based on parameters that you ask. You want to create 25 cases where the chief complaint is shortness of breath, but the other sort of cases are leading to different diagnoses, and you can use these to be a prompt for case-based learning in conference or in sub-internship type classes. That's already out there and seems to be pretty low-hanging fruit, as I said, in terms of using the AI to help you sort of generate some content. This is because I will talk nonstop forever if I don't force myself to take more questions. So if there are any questions now, I'm drinking a glass of soda to refresh myself. Any questions? Okay. So moving on from the sort of, cherry pies and roses, that is all the good things that AI is going to provide for us. There is also some concern. A lot of that centers around ethics and security. We'll talk a little bit about that. But what's not to like? Well, we want our AIs to be good. And a definition of a good AI is one definition is this that I found. A trustworthy AI is safe and fair with managed biases. It's transparent and accountable, explainable and interpretable. We'll talk a little bit about what some of those things mean. And an AI protects human autonomy with an eye towards enhanced privacy, especially in the healthcare setting. So specifically, what's not to like? Well, most of it centers on the idea of where you place the value of humanity, things like liability, copyright, and how we might change the distribution of human resources as AI is sort of interpolated into the world. Who's liable if an AI, which will certainly happen, either makes a diagnosis that leads to harm or helps somebody else make a diagnosis that leads to harm? And right now, there's essentially no case law that describes this. It's a lot of theoretical stuff that is certainly being discussed among the legal circles. But I can imagine that this will be certainly spread evenly amongst all the stakeholders. Certainly the provider will likely have some liability. The provider of the AI or the programmer of the AI will likely have some liability, and the entity that hires them both is going to share some burden. So there's things to worry about, and I'm sure they won't be long before we have our first case law about this. What about copyright and plagiarism? I'm not going to spend a lot of time here. There's certainly a lot of stuff in the media about how everybody and their mother can now write an essay that will fool their professor of English. But the solution to AI is apparently more AI. There's another AI out there called GPT-0, which will tell you if you plug in the text, it will say many of these sentences, this percentage of this text is likely to be AI generated. 20 out of 30 sentences are likely to be AI generated. I don't know that it's too great yet. I just plugged a few in, and it says a lot of them are AI generated or it's likely to be AI generated, but it misses a lot too. So I'm not super concerned about this. I think people should be, but I will, as we often do, just rely on the individual integrity of our selves and our trainees, and I think we'll be able to find out when something doesn't add up. Again, focusing on the human resources, there certainly will be jobs that are, quote unquote, lost as AI is rolled out. There will be other jobs that are gained. You can imagine here that, there's evidence that says that things like diabetes educators that might be currently employed by the hospital to teach people with new diagnosis of diabetes how to manage their diet can be replaced with AI. And so, that might be some of the jobs that are lost or things like that. There's certainly going to be a lot of area for growth for healthcare competent AI programmers. So those will be jobs that are gained, and a lot of our jobs will certainly be changed. Hopefully that means we'll be spending less time doing some of the things that we hate, documentation, etc., clicking boxes, and more time teaching residents, more time with patients, more time focusing on the things that require our actual humanity and not just our presence as a human. Pausing for questions again. We're going to sort of probably one or two more big things and we'll be done. So if you have questions up to this point, let me know.
Steve, it seems like there's no way that this stuff cannot be done without significant editing from our point of view. I'm not even looking at it as the students giving us stuff. I'm looking at us giving the students stuff. And it sounds like I don't see the job loss, because anything that's written, we're going to have to double and triple check for accuracy.
Yeah, I think today that's certainly true. For the future, you know, I think this will probably become as ubiquitous as the internet is for us today, you know, accessing the up-to-date AI instead of up-to-date where we have to search for stuff. The AI was going to know what patient you're seeing. And, you know, you're right, of course, it all is going to be incumbent upon us. So we probably will not lose our jobs. We're going to have to interpret whatever information the AIs give us. The recommendations that they make, we're going to have to agree with or disagree with. And so I don't think physician job loss is likely to be a big problem in the near future, but I do see like some ancillary healthcare providers or healthcare employment stuff is going to be pretty easy to get lost. Coders, for example, AI seems like prime for replacement of human beings coding charts. You know, diabetes educators, similar sort of paraprofessionals like that in the clinic that could have simple versions trained to replace them. I think that is a possibility. But for us at the sort of high level stuff, I think obviously we're all going to have to be aware and take into account what's real and not real. All right, so a little jibe left here. I asked the one of the AIs, this I think was the Bing AI, one of the image generating AIs, you know, show me some pictures of EM residents learning from an AI. And this is a pretty representative situation. It's got a few white coated EM residents learning from a robot who appears to be holding some sort of image computer, and pretty good, better than I could draw. Don't look too closely at things like how many fingers residents will have in the future, but pretty good. There's another picture, more residents looking at a robot intently. Yet a third, and now you're really starting to see a pattern here. Some pattern is a little bit, you know, funny, some weird hands, and some not so funny. It appears that all residents in the future will be men, mostly bearded, probably bespectacled, and, you know, either white or sort of non-specific, non-white men. Yet another, more glasses, white coats, robots. And okay, now we're definitely, this is not just a coincidence. All EM residents will be men and they will have weird hands. What about if you change the question a little bit? What will an attending EM physician teaching EM residents 25 years in the future look like? And good news, we've now got a woman in the picture. She may or may not be being inappropriately touched by one of those graying white dudes in white coats. And they still have problems with their fingers. More white dudes with glasses. And some more of the same. And now the number 25 seems to pop up all over the place. All right. So given that there already seems to be a lot of bias in what an EM resident or EM physician might look like, what kind of bias might we see as AIs are unveiled upon us? Most of which I think you'll be pretty, you know, unsurprised to find out that there is already bias based on sex. Here's a couple of articles that discuss the disparities faced by women and Latino women. There are disparities based on gender. This is by Mike Gazzondi, one of our EM colleagues, and how the LGBTQ plus community is subject to bias. Again, will not surprise any of you that there's a lot of racial and ethnic disparities. There's an entire journal devoted to the health disparities based on racial and ethnic minorities. That's not doesn't bode well for the evidence that is going to go into the AIs. There's bias by us, that is healthcare professionals. Here's a systematic review detailing some of that. This is some colleagues of mine where I trained at Jacobi, Yvette Calderon and Tal Brown, among others, who show that there's still a lot of room to go in emergency medicine as far as diversity, equity, justice, and inclusion is concerned. There's bias in ordinary times. Here's a systematic review of racial and ethnic bias among healthcare professionals and the outcomes that are affected by it. And there's bias in extraordinary times. This is now from a couple of articles by a colleague of mine here at BMC, Dr. Cleveland, who's shown that during our recent pandemic, the crisis standards that were set up for sort of triage of healthcare have a lot of implications for equity on some marginalized groups. There is bias before we're even doctors. Another colleague from Boston Medical Center, who was a chief resident a few years back and is now doing fellowship, shows that there's racial and ethnic barriers, differences in the barriers that people face as they apply for and matriculate into medical school. Dr. Faiz is a great proponent here. Given all this bias that's in the world today, and knowing that the large language models and the future AIs are going to be trained on this data, how is it possible that we could expect the AI to not be biased? And, I'm very clever. I even noticed that there's an AI in the word bias. So how could we expect it to not be biased? I do see a quick chat here. Yeah, that is amazingly creepy. So yeah, hands and faces are hard for me to draw, and apparently also for AIs. So how do we address this bias? The data that you train the AI on has to be diverse, and diverse data is the word diverse is carrying a pretty heavy load there. In order to really mitigate bias, you have to have an infinitely diverse or appropriately diverse data set, which is difficult to gather, as we all know that there are many populations who are overrepresented in terms of poor behaviors by the healthcare system. You can imagine, prisoners or Tuskegee experimentation and things like that. And there are populations who are underrepresented, in particular to treatment of, a lot of diseases were only done on 70-kilogram white men. You can address this by using mathematical trickery. There are tools that I will not pretend to know the details of, things like differential privacy, which is a technical trick whereby you induce noise into the data set in an attempt to mask the factors that could be biased, things like racial and ethnic, gender, language, religion, so on and so forth. And you can use another technique called counterfactual fairness. And those people who build AIs are aware of these things. And for counterfactual fairness, the idea is that you train the AI and you use data sets that are the same, except with and without the bias inducing data. So you feed the AI the same data with race or gender included, and then again with race or gender excluded, and see if you get the same results. And if not, would be concern for bias. As the AIs are unrolled, you have to monitor for bias, and you have to test them frequently, different iterations using different data to see what the effects of the data are on the outcome and the bias that is presented. The builders of the AIs should have the goal that the AI is interpretable and transparent, that is not a black box. You should be able to sort of see how the AI is making its decision along the way, how it's using the data, interpret the importance and reliability of that output along the way. And so there's a lot of things that can be done, but of course it's all subject to the same biases as well. So it's going to be difficult to sort of know how to prevent AI. The goal should be going forward to mitigate it and be aware of it, like it is today. All right, that is officially the sort of last part of the talk. I appreciate your time, and I'm happy to take any questions now. There's just 1 or 2 slides after this just to sort of wrap things up. Any questions?
Steve, I want to thank you. I mean, that's a fantastic talk. It is both creepy and mildly terrifying at the same time, that it is kind of neat that it could be a cool thing to play with in terms of setting up scenarios. Yeah. I think my mind is still a little dazzled, so my questions have not occurred, but please, if anybody else has questions, chime on in.
Please. Again, thank you. thank you so much. I won't play this video again, but you could sort of imagine the ideas that were discussed sort of revolve around the concerns about the AIs in the future. Here's a brief list of most of my references, some of which were self-evident during the talk, so they weren't included, and I'm happy to answer any questions in the future by email or otherwise. Thanks again, everybody, for your time, attention, and for Cord for inviting me.
Wait, Steve, don't go anywhere yet, though, because
I'm not going anywhere.
have they looked at this for like law schools? I mean, I would think that with the huge amounts of text that are generated in law schools, just in terms of other graduate educations and other educational applications, that seems like
I don't know the answer to that. I did not. I mostly confined my interest to my interest, which is the education of medical students and residents. I suspect, of course, that there is, but I'm not intelligent enough to have a conversation about it.
Mm-hmm. Has anyone in the group started using this in their shop much to build scenarios or anything along those lines? Quiet group. Yeah.
I'm like literally preparing right now to, this is Pam, to meet with some medical students over the next week or two to go over their feedback from their OSCEs to generate action plans for them to continue working on. And like, it's blowing my mind that they could just continue to work on the same sorts of things with AI generated cases and feedback and stuff. That seems like a fantastic idea. What was the name of the particular link that a program that does that? Do you remember?
For the like creating case-based scenarios.
Yeah.
The one that we talked about there was
Oh, it's Oscar, right?
That's the OSCE one.
Yeah.
And I think the web link is Oscar with an er.ai. It's Australian. There probably are other examples of it too, but that was the most easily available and ready at hand.
Cool, thanks.
Of course. There are a couple of comments in the chat about using it for discharge instructions. That's certainly one of the things that were talked about. There's a couple of review articles in the references that a lot of people are using it for translation of discharge instructions or translation of research articles, etc. I think that's a pretty straightforward thing that probably people have been using already for like Google Translate, etc. And there was another comment about planning on doing it. So I think the idea is that's probably the way to go. There are certainly easy tools that you can start with, using it to create quizzes and texts and cases that you could sort of talk about that you would have just had to create yourself before, and now you could use the robots to help.
Now, one of the things that I'd heard recently was the concept of like patients actually plugging their symptoms into an AI generator, and especially for maybe like really obscure diagnoses, actually coming up with an answer that had evaded some of the practitioners.
Yeah, so this certainly is in there too, and we often joke now about Dr. Google. You can certainly extrapolate that to Dr. AI. Again, there are certainly times where Google is going to give you the right answer, and I'm sure that AI is going to give you the right answer. But you could also imagine pretty easily that there's going to be, for every one time that the Google or Google AI or Bing AI or Glass AI comes up with the diagnosis that no physician could get over 10 years, there's going to be, X times that number of people who come in thinking that they have a brain tumor or multiple sclerosis because that was listed in the differential diagnosis by their chat GPT search. It's going to be always incumbent upon us to sort of, take that information, evaluate the value that it has, and decide on the next steps.
It does. I see Gillian put in something about the CPC, and it certainly specifically for Cord, then it makes it interesting about doing the CPC competition. And how do you play that out?
Yeah, but again, they don't give the answer. They give you a probabilistic answer. The things are likely to be this based on the information you provided, or likely to be among these things, which is already the training we're doing. I think the idea is that for some of the early training, especially, and practice, that the AIs can be useful to take some of that off the shoulders of senior physicians and put it onto the shoulders of the AI and the learner themselves. And then as the basic training is done and you need to sort of fine tune it, then that will be more the purview of the senior attending or senior educator.
Jillian did just add that in every case, ChatGPT was dead wrong for the diagnosis of the CPC case.
So for at least the near future, then our CPC cases are going to remain untainted.
That's fantastic. That's really, really interesting.
Yeah.
Huh.
Steve, go ahead. Sorry, Lars.
I was just going to say, one would expect that's probably related to the database, right? Or because if Google has right and wrong answers, there's no sort of, honing and culling of like crazy answers. It's probably going to come up with a lot of wrong answers too. But if you give it the right database, I would imagine it's going to be like that super experienced clinician that finds that fascinoma in bed 25 of your ED.
Yep.
Is that
again,
an accurate statement, or do you think?
I think that's pretty accurate. I think that's pretty accurate because a lot of what we do is pattern recognition.
Right.
At least at the level of the emergency department, a lot of our diagnostic stuff is pattern recognition, fast thinking. Once you get past the fast thinking, I am not as clear, and I'm not smart enough to be clear. But for pattern recognition, an AI should be good, right? That's what they're good at, is recognizing patterns. So for all of the things that we rely on our fast thinking, our type 1 versus type 2, I think the AI is going to be helpful. But if you have to sort of force yourself to think outside the box, the AI may or may not be better at that. I think it's relatively easy to understand pattern recognition stuff that might slip by even well-trained emergency physicians. But for the really far out there diagnoses, I'm not sure how practical that kind of AI stuff is going to be in the emergency department. In the hospital, for sure, I think that's probably going to be useful. As I am often reminded and remind people, I love to get the diagnosis, but I don't care if I get the diagnosis. If I haven't gotten the diagnosis and I think it's important, I'll just admit them to the hospital, and somebody or some group of people who are smarter and harder working than I am can figure it out. And maybe that'll include an AI in the future.
Or just have more time and more tests at their disposal, which is usually how those CPC cases are figured out anyway. But,
yes,
I was actually thinking about this because a couple of faculty kind of jokingly did put them in their slides. And I think that, and I'm not sure how this relates to some of the stuff that you mentioned, but I think that's important to think about, that ChatGPT is probably amazing for helping you cover a wide differential diagnosis, but not for getting an answer, because CPC particularly is about uncommon presentations of common problems or common presentations of uncommon problems,
right.
Neither of which ChatGPT or any of these AIs are actually good at.
No, they will likely get better as the data that we use to train them becomes more focused and less all information. Right now, these ChatGPT, Bard, Bing, etc., are all information available to the world. But if you choose the right data to train your AIs, I can imagine that they will get better at things like that. And there's free access to those, the Glass and Tally. I encourage you all to sort of just sign up and play around, with it, just to sort of get an idea of how they work. and how sort of amazingly good they are, at least at a first approximation, and can be useful, and how they might lead people astray as well.
Is there anywhere where AI is overlaying a hospital database like Epic or a regional database? Is that, I mean, I can't imagine that's not happening, but where is it moving? Where have you heard that coming into reality?
I like you, I can't imagine that somebody isn't working on it. I don't have any specifics to sort of quote you that it's happening here or there. I suspect, like a lot of things, it's probably going to happen in Europe or Australasia before it happens here. So keep an eye on those data.
Fascinating, Steve. Thank you very, very much for this. I suspect that there may well be people that are coming up with questions afterwards as they reflect on the application in different areas. So I appreciate you making yourself open to questions and emails in the future. Unless,
thank you.
Yeah,
you're welcome, and thank you again all for your attention and interest.
Good. Do you have like a couple sources for this talk that maybe or is this just kind of, I mean, I would love like a little reference list of just get me started on some of this.
Sure. The last slide of the talk includes a very small font with most of the resources for education, like sort of personalized education, personalized training. The other stuff is sort of self-evident when I'm referring to some of the applications themselves, but you can sort of see where people are in the world. The truth is that this is such a fast moving thing that the citations today are going to have a very short shelf life. You know, there's probably 4 new articles today. There was an article by the CMO or C something of Google, who did an interview with Giamma yesterday. So you can, I haven't had a chance to read it, but there's going to be another article today and another article tomorrow. So it'll be about trying to keep up for, I think, a few years, and then hopefully it'll start to filter out to what the things that are working well and not so well. It will become self-evident.
any other questions from the group? I suspect this is going to be replayed a lot of times by a lot of people. So thank you very, very much. I would actually also suggest to the people who are seeing it, you may want to, once the link comes up, this is such a hot topic, you may want to copy the link and share it with some of your buds in your various institutions. I think that might also be something that would start a lot of conversations, both at the medical school and the hospital level, because clearly this is hot and it's going to be going on.
I'm available to travel, so you let me know and I'll come to your various conferences. Thanks again, everybody. Have a good day.
Thanks, Steve. Thank you very much. Thanks, everybody, for coming, and we'll be doing another session next month. Take care.